Breaking bad news. So, what do you think? What is the bad news? What is the definition of a bad news?
Something that the patient doesn't want to hear or like doesn't like to hear.
Doesn't like to hear. Okay. Mm, okay. Yes. All right. Any other? Can you give us the example, or someone else can give us an example,
Like a bad diagnosis, for example,
like bad diagnosis? What do you mean by bad diagnosis? Wanted to elaborate on bad,
cancer, for example.
like cancer. Okay, that's one example of a bad news. Yeah. All right. Any other example from any other student?
Um, for chronic disease,
Chronic diseases. Yes.
like
Like.
there there will be lifelong treatment.
Mm-hmm. Oh, that needs lifelong treatment. Yes, that's right. Uh, what is difficult in that? Why is it important to discuss this bad news? What do you think? Why do we need to discuss this?
to prepare the patient for the situation.
Preparing the patient for the situation. Okay. Preparing the patient for the situation. That's the component of a bad news. But why it is important? If the patient is prepared, then what will happen?
I can give him like a plan, like what are we going to do.
Okay, then you probably would like to give the patient a plan. How are you going to approach this problem? All right. Okay. So breaking bad news is actually something awful, or something which is very awkward for the patient as well as for the physician, because there are two aspects. One is the patient aspect and the other is the physician's aspect. So we wanted to cater both these things in our consideration. So like here, if you say what is the crucial thing, is the crucial thing is the how you're going to present the bad news. The bad news will remain unpleasant, but the effect of that unpleasantness is going to be different. Like here, the policeman is saying that the cars are all right, but your husband's right off. And obviously, frankly, I think you could have put it better ways. So how you communicate. Second example is the doctor comes out of the theater and he say that to his attendant that you would better sit down. I have some bad news, Mrs. Burton. It's about your late husband. Oops. So this is how you can. This is how awful your bad situation is. So while how you present that situation is going to make some difference, and it's going to change the scenario actually, or change the perception. So giving a bad news is an important communication skill, and you should be aware of that. And it's complex at the same time, which includes why it is complex: responding to the patient's emotional reactions. It is complex involving the patient in the decision making. So this is a challenge. If you wanted to make the patient involve the patient into the decision making, you need to rightly or effectively make the patient aware of the whole situation. Dealing with the stress created, because there is always a stress in terms of the doctor and also in terms of the patient. So stress is actually on both ways. Involvement of the multiple family members, that's these are all factors which makes the bad news more complex. And then you have multiple family members who are in the decision making. As in our culture, the role of family members is very significant, and you cannot ignore that. How to give hope when the situation is bleak, or when the situation is bad? How are you going to give a patient hope but that hope should be realistic and should be achievable. And how are you going to do that? Your communication skills is going to give us a plan. So usually these yani breaking part is very challenging for the physician as well. And many times when you go to into your internship, you will realize that a lot of senior faculties like consultants, they actually try to avoid that and try to make the frontliner breaking bad news person of whether they're an intern or a junior resident. They ask their residents to go and break that bad news in front of the attendants, because consultants many times are very reluctant to break that news. It is a difficult task because it is frequent and stressful. Most patients want to know the truth. So if the patient wants to know the truth, the breaking bad news will remain a bad. Okay, so how are you going to deal with that situation? You obviously cannot change the situation, but what you can change is the presentation, and what you can lay out is a bit of plan. We are required to tell them what they desire, because what is desired from the patient, if the patient wants to know the truth, you have to tell the patient the truth, and that truth is unpleasant and will upset them. So the patient is not going to obviously like that. And we as physicians, we are anxious and fear negative evaluations. So we perceive that, okay, when I tell the patient or the attendant, they're going to be mad at me. So how am I as a physician is going to take care of this problem? So we as family physicians, or as physicians, not just family physicians, as physicians, as healthcare providers, we should be we should be aware of how are we going to deal our own anxious thing, and how are you going to deal our own fear of negative evaluations. We feel, so now we are talking about physician's perspective. We feel a burden of responsibility for the news. So let's first say if we are trying to save a patient who's struggling for his life, and we are not able to do that, so it's going to be a burden for us, obviously, because we did not do it successfully. And on top of it, we need to now communicate this to the attendants or the caregivers. The recipient is already in distress. We are aware that the attendants who are waiting outside for the outcome, they are already distressed, and we don't want to make things worse. So obviously, when the situation is not very good, the recipient is in distress, the doctor feels in burden. So you can imagine how bad that bad situation can be. So we want to be honest, but not destroy the hope. So the art of a physician is that you will remain honest, but you don't need to destroy the hope. Having said that, you are not required to create uh, artificial hope to the patient, and we are therefore reluctant to deliver the bad news. So that's the insight, that we as physicians are very reluctant, because we have a burden. We consider the other thing is that we consider this bad news as the failure of the physician. It's actually not the failure of the physician, it's the situation that we are in front of. And how to overcome that, we will see that what are the ways in which where we can make things a bit better. Now, good news is, with this, while you're breaking a bad news, using a plan for determining the patient's values, their wishes for participation in decision making, and a strategy for addressing their distresses when the bad news is disclosed, can increase our confidence in the task. So if you wanted to make yourself as physician confident, you must have to have some plan, and that plan should also incorporate values of the patient, that the patient or the caregivers, what is his values, and how are we going to break that news. Try to give some warning shots, or try to give some wishes, or how are you going to incorporate their wishes into the participation and decision making. How can you make the patient, the caregivers involved in the decision making by explaining the diseases that look, we have a patient who is on ventilator, and we wanted to wean it off from the ventilator. So you wanted to um, make sure that you inform the relevant person that okay, we are at this stage where the prognosis is like this, and we if we wanted to still continue this, what is the fate of that? So educating the patient is actually, you are involving the patient into the decision making. So if the patient is or the caregiver is involved in the decision making throughout the process, then probably there are less repercussions for this outcome. Whatever is the outcome, the repercussions would be less, the satisfaction would be good. So involve the patient or the caregiver into the decision making, uh, lay out some strategies which can address the distresses, and it will also increase your confidence. So what happens is, when there is a bad situation comes up, the physician is very reluctant to break that news, because it's actually there, he thinks that it's a kind of a failure, and because of that, the situation getting worse, the recipient at the other end are already distressed up, they are already in stress, they are grieved up, and when you are in the stress as well and you lack confidence, so they say that it is because of your fault as a healthcare physician. So that and that way the situation becomes very different. On the contrary, if you have a good structured plan, how are you going to, the plan about how are you going to go through the whole process of this bad news, then it will give you good confidence and it will ease out the situation. It may also encourage the patients to participate in difficult treatment decisions. So if you involve the patient or the caregiver into the situation before, it will decrease the difficulties. um, Maybe quality of life can also be increased. So even though the patient has cancer which is a terminal in a stage, but you still can make other things which can make the patient's life good. Clinicians who are comfortable with giving bad news are subjected to less stress and burnout. So it is a study that the clinicians who are well diverse and well confident in making the good communication skills, they are less stressed and they're less burned out. Because imagine a physician or a consultant who are dealing with terminal patients, cancer patients, oncologists. They are, every other patient is of a bad news. So he should be very well diverse with this. Imagine a physician who are working in emergency department. They are also very stressed up. So every now and there they face deaths, they face MIs, they face unpleasant situations which are coming up in the ER department. If the physicians over there are not very well diverse with how are you going to deal these bad problems in a good way, then obviously it's going to be very stressful, and ultimately it will burn out the physician. So it's a very crucial and important communication that as a healthcare physician we need to be aware of. What we can see here is consultants who are in these healthcare physicians who are in these problems, they are usually not a very good communicator. If you often see the attendants are complaining that we don't know what is going on inside. Whether if the patient is in ICU, the ICU staff is not able to communicate better. If the patient is in the ER physicians are not going to is not going to communicate to the attendants, and that's how the pressure build up, and that's how the confusion goes up. So we need to be very careful about this. Breaking bad news. So what do we want to achieve here? Are we going to treat the patient? Are we going to manage it? Are we going to cure the patient? The answer is no, because we can't do that as a physician. The situation is still bad. So how should we go about it to gather the information from the patient to provide intelligible information in accordance with their needs and desires. So you want as much information as you have about the patient's condition and about the patient's will and the wishes, the more better you will able to handle the situation. And obviously to support them in order to reduce the emotional impact, the isolation experiences that are there, and to develop a plan for the management not in terms of cure but management in terms of managing the symptoms, and cooperation with the patient. You also need to cooperate with the patient and understand his feeling or her feeling that, and lay out the individualized plan that is fit for a particular patient. How are we going to do that? In this presentation, we will focus on just one protocol, which is called Spikes protocol. I think you guys have exposed yourself in the Spikes protocol earlier in your third years. Can you think of what the Spikes means? What S stands for, what P stands for, what I stands for? If you can give me an idea. S stands for what?
Setting up.
Setting up. Okay, what do you mean by setting up?
Not to give bad news just in the corridor or in the hallways. You need to set up in an appropriate environment.
Yes. So yes, very nice. So when you're, it's a kind of a prerequisite of when you are about to break a bad news, you obviously don't do it wherever you are. You need to make sure that the environment is actually good. So environmental factors, which includes up in the setting up the interview, includes, and the second thing, what P stands for? Assessing the patient's perspective. We will go a little deep in each of the individuals in each of the categories. First is the setting up. Second is you want to know the patient's perspective. Third is invitation, that is obtaining the patient's invitation and obtaining the patient's consent, how he should go about it, how she should go about it with the breaking bad news. Does he want to know the whole of it, or he wants to know the gist of it, or he does not want to know the conditions as such. Then after that, it will give the knowledge part or the information part. So we try, as physicians, we try to give the knowledge part at the first, but this is not the right sequence. First, you need to go with above 3 steps, and then the knowledge part comes in between. And knowledge and information is not the only thing that you give. After that, you once you deliver that news, knowledge part or information part is actually delivering the bad news, okay, in a way that is not confrontable. Then addressing the patient's emotions. Obviously there are, it's a bad situation, so you don't expect positive behaviors, but you should try to address these emotions by giving pauses, by giving support, non-verbal clues that can communicate to the patient or the caregiver that we also can feel that. After that, there is a strategy and summary for the S. Strategy and summary. So you need to strategize yourself, and also it is also important to summarize the whole plan that you just go through with the patient or the caregiver. So S is for setting up. P is for S is for setting up. P is for
Precaution.
precaution.
Perception, patient's
Yes.
perception.
Patient's perception. I is for
Invitation.
invitation. Okay. So invitation. K is for
knowledge,
knowledge. So you don't want to give the patient the whole knowledge. All right. E is for
Emotions.
emotions. Now you wanted to know the patient's emotions. How is he grieved, or maybe And then S is for
Summarizing and strategy.
summarizing and strategy. So all of this is one suggested protocol that we give. There are a lot of other protocols, but for the sake of your understanding and standardization, we will follow this. Whenever there is a bad situation, examples of bad situations is you have given me a patient who's terminally ill or cancer patient, any chronic diseases that is going on. Maybe if you wanted to break the news that the patient is diabetic or hypertensive or have some ischemic heart problem or is suffering from MI. So any chronic problems that a patient has. Any other example? So breaking a bad news for a chronic problems, breaking a bad news for terminally ill or cancerous problems. Any other situation where the situation is bad? Any
A
example?
decision to amputate.
Ah, yes, decision to amputate. That's indeed a very difficult situation where you need to amputate a foot. Great. Any other examples?
surgery in very advanced يعني disease.
Okay, if you wanted to plan for a surgery and you obviously need to tell the patient that we are going to do some surgeries out of it. Yeah, I do consider that. Good. Okay. Other examples? The one example could be death if the patient is expired. So you wanted to now know you tell the attendants that the patient is no more. That's a very difficult situation. If you wanted to patient needs ventilator and actually this patient you there is no use of this ventilator in terms of long prognosis. You will prolong the suffering, but you're not going to cure that patient. In that way, going into a ventilator is not a good choice. Or you have put the patient on ventilator and you don't see good clinical outcomes. You wanted to wean off that ventilator. Actually, that's a very difficult situation, and it's very difficult for the attendants to say that okay, you can retrieve um, this this ventilator. So it is also indeed a very difficult task. So setting up an interview, which includes preparation. So that's the main thing. The more you plan your situation, the better the patient outcome would be, or the better the situation would be. Plan for a privacy, significance, and the sitting arrangement should be good. Your non-verbal behaviors should be good. Good timing. If you are in a hurry, you have to see 20 35 patients in a row and there is a bad situation in between. So obviously you can you can reschedule the this appointment into another day where you have a little bit of time, so that you can manage the whole spikes protocol in a comfortable way. Obviously you need to know the privacy, you need to know you need to know the patient is in a good state of to accept or to listen. If he's very lethargic or if he's very stressed up or is very grieved already, then obviously it's not a good choice or it's not a good setup to hold this interview. Second step is you need to assess the patient's perception. So assessing the patient's perception, what do you mean by that?
What are his expectations from the situation?
Number one is actually not number one, but in between, yes, from the expectations that probably the patient would expect that I have a diabetes and I want a cure for this. So obviously this needs to be addressed. Yes, expectation. One is the expectation. Number two. How does the patient already know about this condition? Okay, So before you give to the patient, you need to gather. You need to know, because there are a lot of times we, so that we can conserve our energy. Probably the things that we are going to tell the patient already know it. So there's no point in spending 10-15 minutes explaining the things that he already knows. So how about if you ask the patient, what do you know about your condition? Or um, how can I, how can I help you out, and why you are here? So these kind of things can give your idea that what are the patient expectations, what the patient knows already. So there are a lot of things that the patient already knows it. So you can start your story after the patient ends. So patient's knowledge, if the patient has diabetes or the patient has cancer, how much he already knows about it. And then obviously comes the expectations in between, so that you can make up some realistic expectations. However, be mindful that whatever is the knowledge or whatever is the expectations from the patient, whether is it right or wrong, you don't need to confront it as it is or at then and there. So it will become a very confrontation conversation. And also hopes. Probably the patient is very hopeful for his conditions, so that's okay. And what do they understand about the situation? How is he saying, yani how is he seeing the situation, whether is it unrealistic or a realistic? Then you can also assess what is his state of mind, whether the patient is in grief or the patient is in hurry or the patient is anxious or the patient is angry. Is he giving some hopes? These are the things that you will observe while you give an open-ended question, that what do you know about your condition? So the patient will tell you some knowledge part. The patient will also address some of the expectations. Patient will also do some hopes. Um, and also there is an opportunity where you can correct the misinformation and tailor your information. So correct the misinformation is that you make sure that you don't then and there correct it, but you can list it down and or note it down, and then you later on in the plan maybe you can correct that information. Or also you can do some, you can also tailor your information that okay, this part is already known by the patient, so I think I need to skip that. So that's very important. So patient's perception. I is for patient's invitation. Obtaining the patient's invitation is something different. Patient perception is different. Invitation is different. Same as the gather before you give. How much does the patient want to know? Now it's a invitation is actually a kind of a consent. Um, the patient wants to know the whole of it. The patient wants to know the gist of it. Patient does not want to know delegate some other healthcare professional that I would like to hear from him, and answer the questions, offer to speak to another one. So you can give you can take the patient's consent that you want to be alone, comfortable, you don't want to be alone, you want to accompany someone. Or maybe you can discuss some of the coping strategies if it is relevant, that how you're going to drive back to your home, or is it okay that we discuss today, or you want some other days to schedule and to schedule that. So obtaining I is for obtaining the patient's invitation. K is now knowledge. Now here comes the giving part from your side. In this knowledge, how you should go about it, you should do some warning shots. What are the examples of the warning shot? I'm afraid that I don't have a good news for you. I'm afraid that the results are not very good, not very satisfying, things like that. So the patient knows that, okay, there's something bad going on. The other thing is that use simple language, no jargons. You know that I'm afraid that you have a grade 4 metastatic carcinoma of the breast, which is adenocarcinoma. So patient does not know adenocarcinoma, patient does not know metastatic cancer, stage 4, things like that. So you need to use some simple language and there should be no jargon in it. vocabulary and the comprehension of the patient is also very important. You should know that, yani you should have an idea that the patient is his native language is not English, so you need to be very simple in your words. Or the patient native language is not in Arabic. If the patient is Arabic speaking, so you should use those words which are familiar to him or her, as in context with the language, and also as in context with the culture, because there are some non-medical words that are more acceptable in the culture, so you can use that also, so to make the patients understand. The other tip is give small chunks, avoid detail unless required, give pauses in between, and allow information to sink in. So you need to give some information, do some pause, give some information, do some pause, wait for the responses before continuing. So you need to observe the other response. Okay? It's a kind of an interactive communication. Give in small pieces, make sure that the patient is understanding, do some pauses in between, wait for him to sink, wait for him to comprehend, check understanding. If you think that the patient is not understanding, you can check that, am I making sense to it, what am I saying, or is it understandable. And you can, while you're giving the bad news, you also need to check the impact. If the patient is very grieved or very distressed or is going into denial stage, so obviously you don't want to continue in these situations where the patient is aggressive, where the patient is grieved, extremely grieved, where the patient is defensive, where the patient is offensive. These are all conditions where you need to from where you need to check and check the impact. So while you're giving the knowledge, you need to be aware of these problems. And then fifth step is the emotions. You need to show some empathy. Check the emotions could be shock, emotions could be isolation. Okay, I left alone, and how can I cope up with that? And there is some grief. So it depends on what kind of situation you have, what kind of person you have. You can have different kind of responses, and according to those responses, you should react as a physician. How you can do it? To address emotions, silence is the best thing. You can take, this is the sign and symptoms of the patient becomes silent, patient become disbelief, patient have started crying, patient will go into denial, patient will go into anger. So these are all things that you can come across while you're delivering a bad news as far as the emotions are concerned. Observe the patient's response and identify the emotions. So what your physician, as a physician, you should need to observe it and then respond accordingly. Obviously, if the patient is angry, you don't want to sit alone with the patient, because patient can be angry and later on he will become or she will become aggressive. So you probably would like to take the help of the administrative staff or mm, the paramedical staff in order to handle this situation. So you need to be aware what is going on with the patient. Offer some empathic responses. Okay, you can offer some support as an empathic response, that you can feel the patient's pain, a bit of that. So a bit of on empathy. What is empathy? The capacity to recognize the emotions that are being felt by another person. So sympathy is a lower degree, and empathy is a bit higher degree, where you can recognize the emotions of the other person. So I know exactly how you feel. So this is one way of uh, expressing the empathic aptitude. An indication to the patient that you recognize what they are feeling and why, verbal and non-verbal. So this is not only just on saying verbally, but you can also demonstrate it on non-verbal communication, and often associate with the impact of the news rather than the understanding. So you can use these words: I see that you are you're very grieved, or I appreciate that you're very strong enough to really. So give some supportive kind of evidence, any responses to the patient, so that patient become more strengthful. Wait for the patient responses to digest. And here you also need if you think that there is a need of clarification, you can clarify. Now the step 6 is of strategy and summary. So for the strategies, because it's a long way and it's a very difficult situation, so you wanted to know the patient is ready for this situation, and you are aware that the patient is able to do your, because the strategy requires a lot of effort from the patient and also from the physician. So make sure that you are ready and the patient is ready for the strategy plan. Involve the patient into the decision making. Check the understanding. Clarify the patient's goal. Probably patient wants to attain some specific goals. That doctor, my daughter's son is my daughter's wedding is in near and is in near future. So I wanted to plan these kind of surgeries later on, or I have some financial issues and things like that. So while you're making your own strategy, first you need to involve the patient into the decision making, when he wants to do it, if he's ready to do that, or he wants to do it in some other time. Once the strategy is laid down, you then ask the patient to summarize. The summarization can also be in the end, that is here, or it can also be done in the middle of the conversation while you're doing spike protocol, while you're giving the knowledge. You can ask the patient to summarize over there and then summarize it at the end also. For the strategies and summaries, you should also know that, did you give some follow-up plans? So I should ask the patient to follow him up later on. So it's also very important. So that's about strategies and summaries of this session. So anything, so we discussed spike proto, we discussed breaking bad news examples, and you should be aware that while you're doing some role plays as you have done in your third years, you should know how are you going to incorporate these protocols into your consultation, and make sure that your consultation is complete by incorporating all the ingredients into it. So that's the conclusion of my presentation. Anything or any feedback from the presentation up till now?
No, thank you, doctor. It's clear.
All right. Okay. Anything from the male side?
Clear, doctor. Thank you.
Okay. All right.